Electrolytes. An electrolyte is an ion capable of carrying an electric charge. We've got two types. Anions have a negative charge and move towards the anode, and cations have a positive charge and move towards the cathode. Electrolytes are a very essential component in many processes within the human body and mainly work to maintain osmotic pressure and water distribution. I'm just going to run you through really quick some of the different electrolytes and what their responsibilities are. For things in the body like volume and osmotic regulation, we look at electrolytes such as sodium, chloride, and potassium. For myocardial rhythm and contractility, we look at electrolytes like potassium, magnesium, and calcium. For cofactors and enzyme activation, we look at magnesium, calcium, and zinc, and even blood coagulation. We look at calcium and magnesium. One of the main things that electrolytes are responsible for is water regulation. Water contributes to 40 to 75% of the human's body weight. This declines with age and obesity, and there's less in women than in men due to the higher percent of body fat. Water is the solvent for all processes within the human body. It does things like transport nutrients to the cells. It determines cell volume by its transport into and out of cells. It removes waste products by way of urine, and it acts as the body's coolant by way of sweating. Water is found 2/3 intracellular and 1/3 in extracellular and body compartments. When we talk about water balance in the body, we talk about osmolarity. This is the physical property of a solution based on the concentration of solutes or dissolved particles per kilogram of solvent. If you remember in biology class learning about osmosis, this is the water moving across a semi-permeable membrane in response to a concentration gradient. It's related to changes in properties of the solution relative to pure water. This causes decreases in freezing point and vapor pressure. The clinical significance of osmolality is where osmolality is a parameter to which the hypothalamus responds. The regulation of osmolality affects plasma sodium concentration, and the regulation of sodium in water controls the blood volume. We're looking for a reference range of 275 to 295 milliosmoles per kilogram in the body. So looking at the osmolarity and osmolar gap, there are calculations we can do. The first one, which you are going to have to memorize, is the osmolality. The calculated uses the following formula: 1.86 times the sodium value plus glucose divided by 18 plus BUN divided by 2.8 plus 9. Another way that we do osmolality is using an osmometer. This is an analyzer that uses freezing point depression to determine osmolality. This is considered more accurate. Another thing that we look at is an osmolar gap. This is taking the measured osmolality from the osmometer and subtracting the result we get from the calculated osmolality. While one would think that those would be the same, they're not. And a gap could increase, or there'd be a difference in those two methods if there's a metabolic imbalance or if there's an increase in the ethanol or ethylene glycol in a patient's blood. Here's an example. If your calculated osmolality is 290 and the measured osmolality is 295, you would take 295 minus 290 and the gap would be 5 milliosmoles per kilogram. Here's a nice depiction of how the body helps control water. The kidneys are a major player down here in the bottom. If we do see decreased blood pressure for some reason from a hypovolemia, not having enough hydration, which is what we see up here, we do see a decrease in the renal perfusion pressure in the kidney. The kidney is able to excrete renin, where angiotensinogen is converted to angiotensin 1, which causes some of the aldosterone to be released from the kidney and therefore retain more salt and increase water balance. Some other things that we have is ACE in the lungs, ANP from the heart, and the thirst mechanism that can be turned on in the brain. Another important hormone is antidiuretic hormone, which plays a role in hanging on to water. So I don't expect you at this point in your chemistry to memorize this, but this is something we're going to take a closer look at in the future. I just wanted to give you a depiction of all the different things that help control water balance and osmolality within the body. So when we talk about electrolytes in the lab, we're mainly talking about these four major players: sodium, potassium, chloride, and bicarb. Abnormal levels may be the cause of a whole ton of disorders, and the determination of electrolytes is a major function of the clinical chemistry department. We do a ton of electrolyte testing. You may have learned about active and passive transport in your biology course. There are certain ions that are responsible for this. The extracellular ions, the major extracellular ions, include sodium, chloride, and bicarbonate. Sodium is the major extracellular cation, and chloride is the major extracellular anion. Then we have intracellular ions. Potassium is the major intracellular cation, followed by magnesium, phosphate, and protein. The extracellular and intracellular compositions differ markedly. They need to maintain a certain balance within themselves to make sure the cells stay healthy. The unequal distribution is due to the active transport of sodium from inside to outside against an electrochemical gradient. This active metabolic process requires energy, or ATP, and the sodium pump present in most cell membranes with the transport of potassium in the opposite direction. Hydrogen is also exchanged with sodium, which is important for pH homeostasis in the body. So we're going to take a run through each of the electrolytes, and I'm going to give you an idea of some of the things that you need to be responsible for with these. First, let's look at sodium. He's the most abundant cation in the extracellular fluid. He largely determines osmolality, major player in the osmolality here. The sodium concentration in the extracellular fluid is much larger than inside the cells. And we've got the active transport system to help pump this back and forth. The regulation of this is the intake of water in response to thirst, or polydipsia we call that. It regulates excretion of water and the blood volume status. We do have some clinical applications and some symptoms that we see when the levels get too low or too high. With hyponatremia, or having a low sodium, less than 135, can cause general weakness, mental confusion, impairment, swelling of the central nervous system cells due to the shifting of water, and it can be caused by renal failure. Hypernatremia, having a higher than normal concentration of sodium, can cause things like tremors, irritability, ataxia, confusion, even a coma. It can be masked by other underlying conditions, but in most cases occur in individuals with an altered mental status. They have difficulty rehydrating themselves despite a normal thirst reflex. And a cause with this can be diarrhea, diuretics, dehydration, and Cushing syndrome. With this, we can test serum, plasma, whole blood, urine, and even sweat in the case of cystic fibrosis. We use ion selective electrodes, and the reference range is 136 to 145 millimoles per liter. Our next cation is potassium. He's the major intracellular cation in the body. His concentration is 20 times greater inside cells than outside. He functions for neuromuscular excitability, heart contraction, intracellular volume, and hydrogen ion concentration. Very important. Any fluctuations in potassium can cause some very serious issues with the heart. The kidneys do regulate potassium, and some of the factors that influence the distribution of it is the inhibition of sodium-potassium ATPase pump. Insulin promotes potassium ions entering muscle and liver, and catecholamines promote cellular entry of potassium. Some of the different regulatory issues with potassium is exercise increases your potassium, hyperosmolality depletes your potassium, and we got to watch for cellular breakdown because it can leach potassium into the extracellular fluid. For example, that hemolysis that I talked about. With this, having a hypokalemia is a low potassium and hyperkalemia is a high potassium. Proper collection is very important. We want to avoid hemolysis. We do use ion selective electrodes for this, and the normal range is 3.4 to 5.0 millimoles per liter. Chloride is our next ion. He's the major extracellular anion. He maintains osmolarity, blood volume, electric neutrality, and we find him in the diet. If you think sodium chloride is your common table salt. Some of the things that we see, if somebody has a hyperchloremia or a chloride that's too high, they could have dehydration, they could have renal failure, metabolic acidosis, diarrhea, loss of sodium bicarb, diabetes insipidus, adrenocorticotropic hyperfunction, and extremely high dietary salt intake or overtreatment with saline solutions. With hypochloremia or having a low chloride, we see that in pyelonephritis, which is a kidney infection, or having prolonged vomiting. Your stomach is very full of hydrochloric acid, so if you're throwing up all your hydrochloric acid, it could cause your chloride to go down. We can do this on serum, plasma, urine, sweat, and the ion selective electrodes are what we use in, for sweat. We would use that for cystic fibrosis. 98 to 107 millimoles per liter is your reference range. Our next one is bicarbonate. He's the second most abundant anion in the extracellular fluid, and he's the major component of the buffering system in the blood. He is reabsorbed by the proximal convoluted tubule, 85%, and the distal, which is 15%, convoluted tubules in the kidneys. We see a decrease in him with metabolic acidosis. We can use ion selective electrodes and enzymatic methods, and the reference range is 22 to 29. Magnesium is our fourth most abundant cation in the body. The average human contains 1 mole or 24 grams of magnesium. It's quite a bit. He plays a widespread role in things like glycolysis, transcellular ion support, neuromuscular transmission, synthesis of carbohydrates, proteins, lipids, and nucleic acids, and the release of and response of certain hormones. We find sources that are rich in magnesium to be raw nuts, dry cereal, hard drinking water, vegetables, meats, fruit, and nuts. And the consumption of processed foods can lead to an inadequate intake. The regulation of body magnesium is controlled largely by the kidneys, which can reabsorb it in a deficiency state or excrete it if you have too much. Some of the really important clinical applications of magnesium, having a hypomagnesemia or tetany, which is where your muscles start to seize up, or having hypermagnesianemia. Specimens need to be non-hemolyzed, serum or plasma, and the reference range is 0.6 to 1.0 millimoles per liter. Magnesium is something they also give patients with preterm labor to try and calm down the muscles, where if there's not enough magnesium, the muscles tend to tense up or have tetany. Calcium is our next ion. He is very essential for myocardial contraction. Most people think of calcium as being needed to build bones, but it's just as important for myocardial contraction and muscular contraction. Ionized calcium is closely regulated and has a mean concentration of about 1.18 millimoles per liter. It's very important to maintain normal ionized calcium levels during surgery and in critically ill patients. It's actually regulated by 3 hormones: parathyroid hormone, vitamin D, and calcitonin. 99% of your body calcium is found in bone, and 1% is in the blood or extracellular fluid. Of the total amount in the blood, 45% circulates as free calcium, 40% is bound to protein, and 15% is bound to anions. It's important to know that your body can actually immobilize calcium from your bone into your bloodstream when needed. Some of the things that we do, we use a dye binding method. Total calcium normal is 2.15 to 2.5 millimoles per liter. Ionized calcium is 1.16 to 1.32 millimoles per liter. Ionized calcium is a better indicator of calcium status than total calcium because it is not bound to albumin. Inorganic phosphate or inorganic phosphorus is our next one. It's found everywhere in living cells, and it participates in key biochemical processes. It may be absorbed into the intestine from dietary sources, and it's released from cells into the blood and lost from bone. We find this has an inverse relationship to calcium. We find 80% in the bone and 20% in the soft tissues. Less than 1% is actually found in the serum and plasma. For the specimen, we use a serum or lithium heparin type of sample. And the phosphate method includes a ammonium phosphomolybdate complex. Reference range is 0.78 to 1.42 millimoles per deciliter. Next, we have lactate. Lactate is the byproduct of an emergency mechanism that produces a small amount of ATP when oxygen is severely diminished. When I think of the patients in the laboratories I've worked in as having a high lactate, it's the patients that aren't doing very well in surgery, or the ones that have just come in from a very serious trauma accident. It's not specifically regulated, but the levels rise rapidly when oxygen delivery decreases below a critical level, hence those surgery and those trauma patients. The clinical applications are for metabolic monitoring in those critically ill patients. Avoid using a tourniquet because it can cause lactic acid to go up. We use enzymatic methods, and the reference range is 0.5 to 2.0 millimoles per liter. Some of the calculations that we do in the laboratory for electrolytes include anion gap and that osmolar gap that we talked about. The anion gap is the difference between unmeasured anions and unmeasured cations. It's created by concentration difference between commonly measured cations, which is sodium, potassium, and the anions, which is chloride and bicarb. This is useful for indicating an increase in one or more of the unmeasured anions in the serum, and it's great for quality control of the analyzer, because if a bunch of patients in a row all of a sudden have a high anion gap, there's probably something wrong with your analyzer, not all of your patients. So some of the causes of an elevation can include uremia or renal failure, ketoacidosis, ethylene glycol poisoning, having lactic acidosis, hypernatremia or high sodium, or an error in your analyzer. In order to calculate an anion gap, you take your sodium level plus your potassium level, add those up, and subtract your chloride level plus your bicarb level. Here's an example of some things that might happen with anion gap error. So you see on the left-hand side here, a normal anion gap. One side measures it's got magnesium, calcium, potassium, and sodium. Calcium, magnesium are such a small piece of it that we only use the sodium and potassium. Okay, on that side, which is 142, as you see here, plus 4. And then the other side is all our anions, chloride, bicarb, protein, organic acids, and such. So we're going to take our chloride plus our bicarb, and we're going to figure out the gap. In this case, the gap is 15. If somebody has lactic acidosis like they do on the right-hand side, they might have a sodium of 141 and a potassium of 5. But then on the other side, their chloride is low at 103, and there's a lot more acids and things going on over here. We've got bicarb, protein, organic acids, and things like that, a lot more organic acid. So this is going to make our gap even higher at a level of 21. So somebody with lactic acidosis would have a high gap. The way that we test for ion selective electrodes, or you test for electrolytes, is ion selective electrodes, especially sodium, potassium, and chloride. It uses an electrical potential between the reference and sensing electrodes. Standards are always run with the various analytes to determine the electrical potential at various concentrations, and the patient sample's electrical potential is compared against that standard. So it's a little bit different method than using bulk reagents and things on your analyzer. This is an electrode that can be used over and over and over, and are replaced actually very, very seldomly. And that concludes our section on electrolytes.